So next up, we have someone who needs no introduction in the ketogenic community. He's been one of the major researchers out there for many years. In fact, it was he who had 2 people go to his clinic. Listen up, you guys. 2 patients went to see this doctor and said, I lost weight reading a diet book. How many of you in here have lost weight or improved your health reading a diet book? Raise your hand. See, the influence that you may have on your doctor. That's exactly what happened to this next speaker. His name, of course, is Dr. Eric Westman. Yes, I'm losing my voice. I've been talking all weekend. So, Dr. Eric Westman, and he is the co-author on The New Atkins for a New You. And then I asked him to write with me on the 2 Clarity books, Keto Clarity and Cholesterol Clarity. Who's read those books? Thank you, both of you. So, just kidding. So, is Eric ready? I don't see him. Yes, he's ready. So, ladies and gentlemen, Dr. Eric Westman.
Thank you, Jimmy. It's a pleasure to be here. And how about thank you for Jimmy Moore and Brian Williamson for KetoCon. It's my great pleasure to be here. Thank you for inviting me. And I'm going to give a summary of the scientific support for ketogenic lifestyles in 30 minutes or less, which is impossible to do. But as background, I am a associate professor of medicine at Duke University Medical Center, director of the Duke Lifestyle Medicine Clinic. I'll show some data from the Lifestyle Clinic today. It's in Durham, North Carolina. I have the pleasure of being one of the only course directors of a medical school elective for medical students who want to learn about obesity treatment. This is another area where we need other education. I'm also the past president or chairman of the Obesity Medicine Association, which is the largest group of doctors who treat obesity in the world, not the surgeons, but the medical doctors. I'm a fellow of the Obesity Society, is where we present research. I'm editor of a textbook for physicians called Obesity Evaluation and Treatment Essentials, and I'm co-author on several books, including The New Atkins for a New You. We don't get any royalties from The New Atkins for a New You, but I know it's been very, very helpful, and I hope it's been helpful for you. Steve Finney and Jeff Volek are my co-authors there. Jimmy Moore is a co-author on Keto Clarity and Cholesterol Clarity, and Mike Steelman is a co-author on the textbook. I have 2 conflicts, which I'm actually kind of proud to talk about. In a medical meeting, you hide conflicts, and here I'm happy to say that I'm involved in 2 new companies. These are startups. One, Heal Clinics. We have a booth here. The mission of Heal is to increase the access to low-carb, high-fat, or keto teaching and medical care. The Adapt Your Life company mission is to increase availability of keto-friendly products. So back to the science and the clinical application of low-carb keto. It's really nothing new, which is something that disturbs people or says, why do you have to have a new company? Well, that's a whole long story. But back in the 1860s in London, England, William Banting wrote the Letter on Corpulence, which was basically a low-carb, not quite keto, or it might have been, but he lost this weight and wrote it up, and it became a popular book in England. And obesity was kind of a rare thing then, and until the 1800s, until 1950 or so, you'd go to a doctor to lose weight or fix diabetes, and they would put you on a low-carb diet. They would put you on a keto diet. What happened then was disastrous, and the 1950s, 60s, 70s, well, until today even, the low-fat diet gained prominence, but it's turning a corner, thankfully, largely to grassroots, people like you seeing results and saying, no way, I'm not going to do what my doctor said, or the guidance that governments give, or even other non-governmental organizations. So in Time magazine now in 2014, the headline is Eat Butter. And that was a big turning point in the pop culture. The science is coming around. Even the mainstream scientists in the obesity world who understand lifestyle and diet will say any diet can lead to weight loss. So if your doctor's up on the latest, they'll say, well, it's okay, you can do keto, but any diet can lead to weight loss. Of course, the fine tuning here is that, well, actually low carb did better than low fat, low calorie, but you don't have to tell them that. The main difference, though, is that the metabolic effect is very different depending on what diet you use. So if you want to lower the metabolic syndrome parameters, this is the abdominal girth, the low HDL, the high triglyceride, all those things, lower the insulin level, the low carb diet actually does better. So all diets can lead to weight loss, but the metabolic effect is different. And now you know more than just about every doctor in a primary care practice. And it's tough being the smartest person in the room. You have to, as you heard, you have to be a little tactful, even if the room is your doctor's office. So when it comes to obesity and diabetes, so obesity is, yeah, been there, done that. Meta-analyses, studies of studies showing that it's safe and effective. What about diabetes? There's been a resurgence in looking at this diabetes, and here are the studies. Our study, our contribution was back in 2008, the date of publication, almost 10 years ago now, where we looked at a low glycemic diet and a low carb keto diet. And the way I looked at it was, this is the second study down, if you look Westman on 2008 on the far left column. You go all the way over to the right, the low glycemic, low calorie diet can work. The hemoglobin A1C, which is a reflection of diabetes management and diabetes control, improved. It went down 0.5 in green there on the low glycemic diet at 100 grams of carbs a day. But on 20 grams of carbs, the low carb keto diet worked better. So this is another point of confusion. Yeah, low carb works. It's not the only thing that works, though. Okay, so if you get into that, rabbit hole of this is the only thing, no, it's not the only thing that works. But it can work better for diabetes, for metabolic syndrome, and for weight loss in general. So this is a way to help you speak to other healthcare professionals in a way that's scientific. So the diabetes is still, there was just a review that came out in the last week on diabetes and low carb diets. A study last year by the Virta company also showed diabetes improving. So you're going to see this more and more, but again, it's not to the level that your primary care or even internal medicine doctor will understand or know. What does LCHF mean or keto mean? And this is a common source of confusion. And I'm trying to simplify it here for you with just looking at the total carbs, grams of carbs per day. Now, I don't use net carbs because net carbs assumes that the fiber has a neutral effect on the metabolism. And for a lot of people, that's not true. So if you come to me to get it to work the first time, I'm going to use total carbs. It's a little less confusing because you don't have to subtract things and all that. So anyway, you define a keto diet or a ketogenic diet as some measure of ketones going up. Now here's another level of confusion. We used to say that it was because of the urine ketones going up. That defined a ketogenic diet. Well, but then we have these breath meters. Well, now we define it as breath ketones going, well, it's acetone, not acetoacetate that was in the urine. And now we have the blood meters that measure beta-hydroxybutyrate. And now, is that what ketosis is? Well, nobody really knows how to define it. Although, you could have put it all together and say some measure of ketones goes up. That's how you define it. So I think that's a useful way to do it. So you've crossed some ketone threshold, whether it's breath, blood, or urine, they hang together pretty well. Although most patients in my clinic don't even measure ketones because they get the proper teaching. So if you go below the ketone threshold, usually that's 50 grams of total carbs a day. No, usually if you want everyone to have ketones, it's going to be 20 grams total carbs per day. Probably the most common mistake I see is people are having too many carbs. They're using net carbs when they really should be using total carbs. And that defines the low-carb ketogenic diet when you have that ketone increase in the blood or breath or urine, and you lose weight, your hunger goes away. Common source of confusion is what books or how do you learn about keto diets? And there are all these different names of diets and all that. So not all low-carb diets are keto. And in our paper from 2007, we basically define these strictly speaking with the 50 gram below And so if you're doing a scientific study or you're saying or someone says there's no definition, yeah, actually there is. Probably the best source of information now, have you noticed it's kind of an access issue to the information? Well, the Public Health Collaboration in the UK now has, within 3 clicks on your smartphone, a way to access all of the randomized trials that compared the low-carb diet to the low-fat, low-calorie diet. Look up Public Health Collaboration, the evidence, and you can put it in your doctor's face in the clinic room, or you can use it to educate people if they need to be educated. So that's the best source of information today, is to just use that smartphone. Keto doesn't necessarily mean no carbs, although low carb means there are good carbs and bad carbs. Roughly speaking, or generally speaking, the vegetables are sources of good carbs. And a variation on a keto diet could be as simple as eat as much as you want of the meat, poultry, seafood, and eggs, limited amounts of salad greens and vegetables. If you're at 1 cup of vegetables, 2 cups of salad greens, that's your 20 total carbs for the day. If you're doing net carbs, you might have an extra 2 cups of the non-starchy vegetables. Limited amounts of high-calorie things. Most common mistake number 2 I see is the indiscriminate adding of butter, MCT, coconut oil to drinks. You drink them. We don't meter the calories through the drinks well at all. So no calories through the beverages, or limit them strictly. That will help a lot of people get through a stall on a keto diet. The Lifestyle Medicine Clinic, we started in 2006. So 11 years ago, after, in my mind and in Dr. Yancey's mind at Duke, the phase 3 clinical trials were done, which basically this is using the construct of a medication. What would be the requirement to approve a medicine at the US FDA level? And so we thought, with all the studies being done, that that was already done. Sign it off, yeah, it's FDA approved, just like a drug you would purchase from the drug company pharmacy. So we opened the clinic. It's a university-based private practice using 2 rooms adjacent to an internal medicine teaching clinic. So I'm a teacher, a general internal medicine doctor at the academic center, while now I'm an obesity medicine doctor and internal medicine doctor as well. It's basically, the full-time staff is myself, an obesity medicine specialist, and a clinical nurse assistant. There's no dietitian, there's no exercise physiologist, there's no behavioral person, there's no it's just using really the diet and the education. A 1-hour teaching class of how to do it, and then I see people back one-on-one in the clinic. The payment is within the private or public insurance system. A lot of people are under the false impression that a doctor can't get paid for treating obesity or diabetes and all these things. Actually, they can. There's just a little nuance or extra training they have to have. And the first-line treatment at the Duke Lifestyle Medicine Clinic has been the low-carb ketogenic diet. That's, okay, another point of confusion. We called it the low-carb ketogenic diet in the research studies. Dr. Feynman called it the carbohydrate-restricted diet. Jeff Vola called it the very low-calorie, very low-carbohydrate keto. It's all talking about the same thing. So this is the keto LCHF. Yeah, not all LCHFs are keto, or just plain keto, if you want to look at the synonym. So at the Lifestyle Medicine Clinic, we did a quality improvement sort of study where we looked as best we could at clinical data out of this computer database. And over the last 10 years, we've seen on the far left here 4,000 patients with 28,000 clinic visits. You know, the people in charge of the money like that we see lots of people and charge for it. The patient characteristics in our practice are the average age about 51 years old. Most people are female, 74% female. Half are Caucasian, half are African American in Durham, North Carolina. That's the patient mix we have. And the average BMI is 40.5. The average BMI body mass index for African Americans are about 10 points higher than for Caucasians in our clinic. So over the last results, so 5 years ago, over the last 5 years, 5 years ago, the computer made a switch so that I'm more confident, much more confident with the data. with some double checking of, and I think this will be publishable as a clinical trialist. It's not as high level of evidence as doing a clinical trial on my own, but over the last 5 years, I can pretty confidently say that we've helped 2,000 patients lose 26,000 pounds. So, if someone says there's no proof, actually, this is like saying that a doctor using a drug that's already FDA approved has to show in their own practice that the drug that's already FDA approved works in their clinical practice. This is a double standard to actually ask a doctor to show that something that's already approved to show that it's already been proven, right? Just another issue to keep in mind. So at Duke, I've been known now to lead what's known as the clinic of last resort. People have tried everything. I've tried this diet, I've tried that diet, I've tried drugs, I've tried surgery, I've tried all these things, and then they end up in my clinic. And what do? I cut the carbs. It's that simple. So the clinic of last resort, I've treated diabetes, type 1 and type 2 diabetes, polycystic ovary syndrome, irritable bowel syndrome, fatty liver, and GERD. These are conditions where there's publications, at least at the pilot study level, in the medical literature. The second bullet there, heart failure. I have pre-heart transplant patients who have to lose weight in order to get their heart transplant. And if you're familiar with this, the heart is so bad that there's a tube that goes into one side of the heart, and then there's an implanted pump in the chest, and then the other tube goes into the big artery in the chest. So basically, they have no heart function. I treat them. Now I have 2 people out of the 12 so far who have already gone back to heart transplant, which is a great hurrah. You know, it's a heroic thing, and yet it's just cutting carbs. Now, there's a variation on this diet which does account for low vitamin K because of the anticoagulation that everyone is on, because if you're not anticoagulated with this pump, you'll clot. And then the other thing is a sodium restriction that is added on. So, you know, don't do this at home without some guidance, please. Lymphedema, post-bariatric surgery, weight regain. The advantages of this way of doing things is that there are no new medications. There are no products you have to buy. It's just the understanding of how your body works in regard to the food you eat. The nice thing about the ketogenic diet is it can work in conditions that require medications, like steroids. I have lots of people, anti-inflammatories and steroids, that still lose weight on the keto diet. Focusing just a little bit on diabetes because as Willie Sutton says, that's where the money is in terms of the medical system. So much money is being spent now on treating diabetes with medications and treating the long-term consequences of diabetes like blindness, kidney failure, neuropathy. The LCHF diet or keto diet can put type 2 diabetes into remission. And here are just some examples. This is one individual per slide. You add up all of the insulin, doesn't matter if it's long-acting, short-acting, the 300 or 500 units, or it doesn't matter what kind of insulin, you add it all up. If someone has pretty good control in the hundreds milligram per deciliter, you have to be careful. People will get low blood sugars if you don't cut the insulin back. The medications are adjusted to the carbs in the diet. So reduce the insulin by 50% on the first day. Look people in the eye and say, will you follow this? Will you measure your blood sugars? If yes, you follow them. And this person was off 80 units of insulin in 1 week. Pretty cool, right? Remember, this is with the confidence of a drug that's FDA approved, this will work. Oh, but then I say, if you don't take the pill, you don't blame the pill for not working, right? So if you do this, it will work. Now, if every doctor said that about this, imagine the difference in your confidence to be able to do it or to expect it to work. So this person, new person, off 100 units of insulin in 6 weeks without any weight loss to speak of, down 5 pounds. So basically, the first thing to learn is that there's food that contributes to the elevated blood glucose, which is the definition of diabetes. The second part of it is the weight, but the food can be a huge component. This person had been on insulin for 10 years, stopped in 1 week just by changing the diet. This next person off what, 160 units total, you add it all up. Now we're getting to the detail down here on the third row at the bottom. This person was on 5 shots, 30, 25, 25 of the short-acting and 40 of the long-acting, and is off it by the 6th week. It's so unbelievable, people don't believe it. But it's true. It doesn't seem to matter how much insulin. 275 units of insulin stopped after 4 weeks. Pretty amazing. Oh, yes, the mechanists people will say, but oh, that person lost weight, you cheated. I'm like, no, that's just part of the whole package. And this is a problem when you're trying to get NIH, US NIH funding, National Institutes of Health, because they want you to just manipulate one variable. And actually you do get the food, glycemic control, and the weight loss in all one fell swoop. It's actually pretty great. 500 units a day, carbs stopped on that first day, and then off 400 units by week 10. Now this gentleman is interesting. I mean, he still has a weight problem with the weight down there, second row from the bottom, 264 pounds. He's about 5 foot tall, and he went from not being able to walk around Walmart because he was in one of these electric chairs, scooters. Now he's walking, so he's not a very active guy. And so the second message is it's not just the food that affects the diabetes, it's also the abdominal obesity causing insulin resistance. So you may have somebody who doesn't come off insulin immediately, that's okay. You just have to continue with the weight loss, with the lifestyle change in this case. So in this person, insulin was still required after 6 months of the low-carb ketogenic diet, keto diet, but you can see the improvements on much less insulin with blood sugars as good or better than before, and still has weight to lose. So I'm in this world of immediate gratification isn't fast enough. I'm hearing, well, people want to go back to carbs because they're not off all of their medicines in 2 weeks, even though it took them 10 years to get to this point within the diabetes illness. So a lot of instruction and reassurance and support and understanding about how things will change, and it may not be immediate. Now, we also do violate the guidelines. It doesn't mean we're wrong, it means the guidelines need to change. This is one part of the world, even the medical world, where the guidelines have been intransigent due to other factors other than science. And so this violates the guidelines. Any new onset diabetic with 10.5 hemoglobin A1C, this is really high, this person should have been placed on insulin. I'm sorry, I violated the guideline because he said, yeah, I'll do the low carb diet. And so he was off the diabetic diagnosis or definition within a few months and kept it off now for several years just by not eating carbohydrate. So, turn me in, I violated the guideline yet again. It's okay. The guidelines need to change. So here are proven uses of LCHF. Yeah. Just to wrap up, there are levels of evidence, we call it. These are solid, proven uses of LCHF or keto. Obesity, metabolic syndrome, that's the HDL, triglyceride, all that thing. Type 2 diabetes, type 1 diabetes improves, just less insulin is needed. GERD, that's heartburn, PCOS, polycystic ovary syndrome, fatty liver, NAFL, IBS, irritable bowel syndrome, epilepsy. The world is an interesting change agent, and you can change things. This is the effect of a father of a child with type 1 diabetes who created a Facebook group, and now one of our fellows surveyed the Facebook group members, and so this is the Keto Type 1 Grit Facebook group of people with type 1 diabetes and doing low carb. 52 adults and 41 children were in this survey, and at the very bottom you can see the A1C improvement in the adults from 7.8% to 5.2%, and for children from 8.0% to 6.4%. This is a drug-like effect, and they're on less insulin with better blood sugar control. The parents of the children say we do this because there are no low blood sugars. The parents are terrified that the low blood sugar will happen in the middle of the night and the child won't wake up. So the main reason type 1s do this kind of diet is to eliminate the low blood sugars that can be deadly. Lymphedema, lipedema, this is another area that it was said there was nothing you could do. And yet Facebook groups, small studies being done, leading to larger ones. Pretty exciting to see. I got to go to a conference on the lymphedema, lipedema, and the world expert, basically the center where people go, is run by a bariatric surgeon. So of course his view is that everything has to be surgical, just a surgical approach. Well, that's not true. The low carb or keto can also work in this condition. Now, promising uses mean that I can't sign off with the same confidence as a FDA-approved drug. Cancer, Alzheimer's, traumatic brain injury, glycogen storage disease. That's interesting. At a meeting last year, 4 people got up in the front of the meeting and said they had McArdle's disease and they were all better. So we wrestled together some scientists to track them down and get their stories, and that was published within a year, the clinical stories of these people with McArdle's. And so that's now changing. So that what you see or what you're doing can change the scientists' projects by providing things that can work in areas where there's nothing else to use. So you can actually change, and I like to help make that transition back from the clinic to the researchers. So just to summarize, the LCHF or keto lifestyle, over the last 15 years, the evidence for keto has surpassed the evidence required to approve a new drug. If you know this language, that's the phase 3 studies, and then what happens to a drug is it goes into phase 4 marketing. So that's where you might have a side effect, you send in your form, and the government still looks at these side effects. The thing about keto is that the phase 4 marketing was done before the phase 3 studies. The hunter-gatherer diet, the idea that the Banting diet, and every doctor was doing this, prescribing it before 1950, I'm afraid has been forgotten. The low-carb, high-fat, or keto lifestyle is healthy. It can be used as a therapy for chronic medical conditions as well, like I've shown today. Individuals with medical conditions require special consideration and medical monitoring, and as we roll this out into new areas, just be very careful if you're on medication and you don't know what the medicine's doing or how to monitor it. That's why we believe you need to see a doctor in a clinic who understands the effect of this kind of approach. If you have medical problems, we still believe that strongly. And the optimization, as you've seen today with these great presentations at this conference, the optimization may include additional support in keto-friendly foods, Facebook groups, your support at conferences like this, and thank you very much for letting me speak. Have a few minutes for questions if you have some. Yes.
Dr. Westman, I like to eat a lot of cruciferous vegetables and asparagus and broccoli and things like that. Am I sabotaging my efforts in keto by doing that?
So in the teaching that I give, which is sort of the basic 101, it's really a matter of how many of those vegetables you're going to be eating. That's the amount of carbohydrate that you eat can raise insulin levels, which then turn off the ketone production internally. So I don't have any problem with cruciferous vegetables or any non-starchy veggie in terms of the ketosis. It can happen. So what is your concern about cruciferous vegetables?
Well, I just want to know if I'm eating, like, some of the keto advocates say, you can eat as many green leafy vegetables as you want. I mean, be sure you're getting high fat and moderate protein. And
how's that working for you?
Well, I'm kind of stalled out. So that's what I'm asking. I'm asking, well, should I start backing off on the vegetables somewhat?
Are you in ketosis?
Yes.
Then you don't have to.
Okay.
So actually there's two conversations I see going on. One is ketosis for weight loss or diabetes improvement. And then there's ketosis for a therapy, for cancer, for some other, for running, for endurance performance. The level of ketosis really doesn't matter for diabetes or obesity. In fact, the most common mistake I see is that people are adding fat thinking that they're going to get more ketosis when fat has calories in it. But that's for the diabetes and obesity world. If you're trying to optimize a ketone level for some other reason, you feel better at a certain level, you're checking. I get people who come to me with reams of data on what they're measuring and all this, and you can do that, and then you just find your own tolerance for the ketones, and you manipulate your vegetables likewise.
So you're saying basically if you're in ketosis and that's all that really matters as far as if you're in, like metabolic syndrome is my problem. It doesn't really matter how many vegetables you're eating as long as you're in ketosis.
What are you trying to accomplish? Weight loss, diabetes?
Yeah, weight loss and elevated blood sugar.
Then you have to be mindful of the calories.
Okay.
And so ketosis, being a fat burner, doesn't mean you're going to lose fat weight. If you're a fat burner, so you've changed your energy from mainly carbohydrates to mainly fat, but now you're eating more fat than you're burning for the day, you're not going to access your fat store, right? So there's no magic about a keto diet in terms of weight loss. It just leads to a low-calorie diet in most people.
Okay. I guess one more point I wanted to ask was that...
I think next question,
right.
yeah. Ask me afterwards. I'll be here all day.
I hope I can explain this. I have a fear. I've lived with my husband for 40 years with type 1 diabetes. He has all the problems, heart problems, osteoporosis, and such. So 2 years I've been real strong keto, and I've added a lot of fat to his diet. He continues to eat his sugar. He continues to eat his pasta and carbohydrates, but always with fat, and we also do a little MCT oil. So my fear is all the things I hear that you can't add both.
About sugar, you mean?
Fear.
About eating sugar?
Yeah, well,
yeah,
that's true. But here's what I want to tell you. We call 911 3 to 5 times a year. I have found him unconscious. He's been in convulsions. We spent nights in hospital. Yeah. For the last 2 years, I have not called 911.
Can you rephrase that? I don't think everyone heard the importance of what you just said.
The last 2 years, I have not called 911 when I normally call them 3 to 5 times a year, and we spend the night in the hospital because of low blood sugar.
And what was the change that
The fat I've added to his diet. Even though he continues to eat the SAD diet, he eats along with me, but we add fat to everything he eats.
Is he in ketosis?
I don't know. I don't know.
So
don't test him.
This is a question for the type 1 grit.
He's a very thin person.
Go post this at type 1 grit.
Okay. All right. I just wanted you to know that. And
that's awesome.
And am I adding, I know it's good that he's not hitting, and when he feels his low blood sugar now, he knows it. And so he goes and does something for it, which used to be it would be me that would be the one to notice it.
That's great. So
just wanted to know.
What may be going on is, if you are in ketosis, if you do have an increase in ketone levels and you're burning those ketones, the blood glucose level isn't so important. And I see people which would be diagnosed as low blood sugar on the lab test, and they feel fine because they're running on ketones. As Jeff Volek says, Jeff Volek at Ohio State, you don't need the glucose as much because you're running on ketones. And even in the context of type 1, I wonder if that's going on. Thank you for that comment.
We're all out of time, you guys, so sorry about that. Go find Dr. Westman after it. Dr. Eric Westman.